people should see a notification that this is being recorded. So that's just to make everybody aware of that so that we can share the presentation afterwards as well. So yeah, thank you everyone for tuning in for yet another Open Digital Health event. My name is Sebastian Potthoff and I'm one of the directors of Open Digital Health. And I'm facilitating today's event, and it is my absolute pleasure to welcome Professor Richard Sinnett with us today, who is joining us all the way from Melbourne, Australia, where it's already, I think, 7 p.m. So he's joining us very late and giving his time, which we're very grateful for. Professor Sinnett is a professor of applied computing systems at the University of Melbourne. He has been technical lead on a multitude of large international projects with an emphasis on big data and security worth over $500 million. This includes numerous projects in the defense, intelligence, and biochemical domains. He has over 450 peer-reviewed publications across a range of computing and application-specific domains. And today he will give a presentation on lessons learned in developing and supporting international health research platforms. So at this point, I will hand it over to Richard. Thank you very much.
Thank you very much for the kind introduction. I had penciled in about half an hour for the talk and maybe some time for discussion. And so hopefully it's not going to be too long and boring for people. So as has been just mentioned there, I am the director of something called the Melbourne eResearch Group. So my job at the University of Melbourne is to build software for researchers. So the University of Melbourne can give you a laptop and fix your printer, but they can't build you a cancer database. I've done this job for many years now. Before I came to Melbourne, I was at the University of Glasgow in Scotland, and I was the director of the National E-Science Centre there. And again, my job was there largely about building software for research communities to do things that they couldn't do otherwise. I can hear people talking. I'll just carry on. I'll just keep talking. I think there's someone needs to go.
Sorry, I have resolved this now.
All right, okay. So anyway, so I came to Melbourne in 2010, and I have since grown a team of software engineers that work on all kinds of different projects. I tend to get lots of large grants, not because I'm an amazingly talented researcher in my own right, although I think I'm great. It's really because I build things that people use. And the people I work with tend to get the larger grants. These are people who work with, say, US Defense, DARPA, or US Intelligence, so the IARPA. I have a lot of major contracts with defense people over here, the Army, the Navy, the Air Force, etc. But I guess most of my work, generally speaking, is not for me. It's for other people. So I'm very much in the background. If you think of medical publications, they might have a methods section. I generally am the anonymous contributor to those papers, and I am Mr. Methods or Mr. Data Collection. I teach one subject at the university here. I teach cloud computing and high performance computing, and I get to supervise literally hundreds of dissertations. So I have many, many projects that students can work on and as part of their dissertations, and they all have to have a dissertation to graduate. My team cover the full gamut of software from cloud infrastructure, security, mobile apps, big data platforms, user interfaces, the whole, if it's digital, we generally speaking can do it. That's kind of our goal, I guess, is to be the software engineering company within the University of Melbourne. That's kind of what we do. And everyone in my team, with the exception of myself, is on contracts which are externally funded. So I need to generate a lot of money all the time to keep everybody employed. And so that's really my main job around here right now, is to keep everything going. And that's what I've been doing for the last 12 years, I guess. In terms of the biomedical community, I've done a lot of work in that area. My main focus, I guess, in all of my projects tends to be dealing with data and dealing with security. So it's very rare that someone would come to me and say, can you make my algorithm go faster? it's nearly always all this data is out there on the internet or behind hospital firewalls. Can you make it all come together because we're a collection of researchers interested in a given topic? And I've worked in many, many projects in this area. So if I had to try and summarize the kind of things that people generally want me to do when we work with them, it's nearly always data driven, sort of in the medical domain. It's imaging data, it's genomics data, it's clinical data, it's treatment data, etc. More often than not, it's bringing data together from different organizations. So it might be different hospitals, it might be research laboratories. In doing that, you're often challenged with dealing with security and privacy and confidentiality. A lot of the time, my work stops there, but many people these days are interested in things such as analyzing the data and applying next generation technologies, such as machine learning and image recognition and neural networks and those kind of things, and doing more advanced visualizations like 3D models of the heart and things like that. But there's a whole variety. I guess the first few are the ones that really are where most people who come to me are asking me to do those kinds of things. The technology is one part of building these systems, but there is a world of pain, I guess, which is probably a good thing in terms of being allowed to apply these technologies and being allowed to have access to sensitive data. So there is hospitals who have policies on what can be done. There is the procedures about getting access to it and consent of patients. And there's this whole world of GDPR, which I guess everyone's familiar with now, about people should have the right to know what data is being collected about them and how it's being used, etc. All those things have to be sorted out before we start building systems which aggregate or collect data and use it for research publications. And I guess another key part of what I do is the trust relationship with the communities I serve. So I'm very much in my work, I get lots of grants, obviously, but more often than not, the reason I get them is that when I get these grants, I sustain them long term. And so I'm not just in it for give me money and I'll do it now. Once I've got the money, I sort of promise that I will continue to support the systems I deliver after the money has ended, as long as the people are using it. So I do that a lot, where it's pro bono long-term support is what I generally do. In doing this, as well as a software engineer and as a domain scientist, I often have to engage directly in the science itself. I am not a cancer specialist. I'm not a diabetes specialist. I'm not a clinician by any stretch of the imagination. But to really solve a lot of the problems, you really have to, have a familiarity, I guess you can say, with what they're trying to do and how the technology can fit in. It's less about just building technology and more about understanding what their real problems are. And then, of course, the delivery of these systems and listening to the customer, even if the customer is always right, even if they've said what they wanted and then we built it and then they changed their mind, there is always an element of that as well. In terms of data, I guess I've worked with probably more hospitals than I can remember now, or more organizations that deal with sensitive data. The data is generally always fragmented. It's always inconsistent. It has, some sites use different coding techniques. Some are using ICD-9, ICD-10. Some of them aren't using anything. Some of them have got a wonderful database, or some of them have got a commercial solution, or some sites are just using Excel spreadsheets for everything. And it's generally speaking a bit of a patchwork quilt or a dog's dinner, depending on how you want to consider the challenges of working in the biomedical and the clinical domain. And so my job, generally speaking, is to solve those problems. If those problems did not exist, I would not have anywhere near as many projects as I do. And my job, generally speaking, is demonstrating that all that heterogeneous distributed data can be brought together in a secure way to support clinical or biomedical research. And I have to do that very rapidly. It's not the case that I can spend 3 years building a system that doesn't work. I have to be able to demonstrate it very rapidly that I can do these kind of things. And this is kind of one of the tricks to delivery. I mean, you're getting feedback from customers as soon as possible. So I don't have a CD where you can say, this is how you do it. Generally speaking, my team build things from the ground up. We learn how these things work. We learn about the technologies and what works and doesn't work. And there are certain technical solutions that we've adopted over time. And then, but more often than not, it's listening to what the customer wants and then being able to build a solution that will solve their problems. And if I had to generalize the way how we do it right now, there are a range of data sharing models I've looked into in my team over the last 20 years, I guess you could say. So one of them, which is I've worked in projects where the data, like genomics data is a good example, building systems that can just talk to lots and lots of different open, accessible databases on the web, and running queries across all of that and bringing it together for the researchers to tell them about the different genes and who's published papers on them, etc. So we've done lots of work in that space, and it's a bit of a messy, horrible thing to do, but it's fairly straightforward technology if you know how to build federated query systems. So that's kind of a known thing, give or take. More often than not, though, most people come to me and they want me to build them a system, which is generally speaking independent of the hospitals that are scattered around the world. And I will give you one example of this later, which is to do with adrenal tumors. And this is one of my most successful projects. But this system doesn't reuse existing data. It does not interface to any kind of heterogeneous hospital systems at all. This is very much a set of doctors or clinicians or researchers around the world will log into a system that my team build and enter information on the patients and how they're being treated, etc. And that's generally a very common model for, say, disease registries. But it's independent of all the existing hospital systems. The systems are hosted on the infrastructure at the University of Melbourne in a private cloud that we have available. My job is to make sure those systems are secure and no one can access them, and the researchers are comfortable with putting the data in. And as I say, I'll talk about one of those projects in particular. Sometimes you can't do that. Sometimes you want to be able to reuse the existing data existing in hospitals. For example, if it's to do with brain trauma and you need to get all the information in real time, then you can't just have someone manually entering it. It has to be pulled out of the hospitals. I will give an example of another project that does this, which is called the ADDN, the Australian. This is the National Diabetes Registry that my team built for Australia, which is reusing hospital data and the various challenges in doing that. But they're not the only models. There are other models I've built over time where I can't go through the firewall, but I can pull queries into the firewall and run some analysis on sensitive data and then feed data out after it's passed various privacy checks. Sometimes that model is required in the particular scenarios that we've worked with, say with the Department of Health here in Victoria. The ideal one, though, would be all hospitals around the world and everyone who was dealing with sensitive data had finer-grained security systems where you could authenticate and authorize, and it would be auditable, etc. And I could just build in systems that can talk to all those remote systems and then query them, and they would understand who I am, what role I have, what privileges I have, and have automated security technologies to say, yes, you're allowed, or no, you're not. The reality is that doesn't exist. I mean, the vast majority of hospitals I've ever worked with, this is far removed from how they do their business. They typically have a thing called a firewall, and that's it. They don't know how to do finer-grained access control, limiting access to sensitive data or not for different scenarios. But each of these models I've implemented in many ways in many projects. Some of the projects I've implemented have been amazingly successful and gone global, I guess. Some of them I've built exactly what the customer wanted, and they didn't really engage for whatever reasons, which I haven't, that can happen. And it's not always a technical issue. It's more about the customer didn't know what they wanted, or they knew what they wanted, but when they got it, the technologies or the science had moved on, and so they didn't need it anymore. A key aspect as well is being fast. I'm a great believer, if you're very good at what you do, you get grants. And if you can build things very rapidly and they deliver what customers want, those customers will keep coming back to you with their researchers. And being agile is key to this. So my team are very much an agile shop. We have experts in various areas, we swarm around each project, and I might have 3 or 4 techies working on it at any given time, even though that project only funds 1 person. But that kind of continuous delivery using extended skill sets of a range of engineers is very powerful, as opposed to a grant that pays for 2 people and only 2 people. You will never have all of the things that are required in just 2 people if you're dealing with real major infrastructure. So I'll give 2 examples of this, and I'll speed things along. So one of them was this European project, which I was at the University of Glasgow before I came out to Melbourne, and I had a bunch of European projects funded just as I was leaving. So this was one I actually brought with me because the software engineer wanted to come out with me to Australia. So I brought this project with me. It was focused on adrenal tumors. And for those who don't know, your adrenal glands are right next to your kidneys, and you can get various types of cancer of the adrenal gland. Unfortunately, if you get one, the prognosis is not very good. You will not really know you have a cancer there. You might have slightly elevated blood pressure and a slight sort of stiffness in the lower back. But other than that, you wouldn't know. And by the time you do know, the cancer's already metastasized, and it's, the chances of your survival is very poor. But there are different types of cancers that you can have. And this community, the European Network Community for Study of Adrenal Tumors, came to me and said, can I build this system? I said, yes. They gave me a few $1,000s to start with to say, well, prove us that you can do what you do. We built that system in 6 weeks. That then led into a European grant, and that grant got funded. It was €6 million or so. And so this system still runs. We're still hosting and running it now. But it was really building a set of databases for a community who were interested in these different cancer types. There were other aspirational aspects as well, which they were looking into. They wanted to do imaging and analysis, and they wanted access to physical biospecimens and biobanking. And they had ideas of this could be used for clinical trials. This is where this project started. Where we got to, there are now 121 hospitals around the world using this system. They're from Brazil to Russia to all over Europe, etc., and Australia. These cancers are extremely rare. So but we have 22,000 patients in the system right now. There are 39,000 physical biospecimens, and we can tell you which fridge, which rack, which test tube is sample number 23 from patient number 4, etc. What's key to this system is what we call clinical annotations. If a patient has a treatment, they might have surgery, they might have a biopsy, they might be taking a certain drug or having chemotherapy, then that is one annotation. So we have thousands and thousands of annotations. This is a very, very rich data set of information which is being collected on all of these patients with these cancer types. And the reason we collect all of this is that often the researchers themselves are looking for, I need 500 patients for my particular study, which I'm trying to get funding for. And they can see these patients may or may not exist in the system. And then if they do exist, what's key to the success of this system is that there is no obligation for any researcher to share all this information. So people can put data into the system and say, only people from my center can access it, or only people from France can access it. But they can also, you can use this system for doing sort of discovery and saying, oh, your patient meets the criteria for all of for my study, but can I have more information, or could I have a biospecimen because we're interested in? And they can say no, or they can say yes, but your data in patients number 22 and 55 is also interesting to me. How about we collaborate? So the researchers themselves, the clinicians, in who can access what data. This isn't a simple system where all the data exists and everyone's just using everything. My having worked a lot in this domain, I know collaborators are also competitors, and there is a lot of pressure to publish. And if everyone was sharing everything, then there's real challenges in that, I guess. But the system is then used for many, many clinical trials. We have about 40 ongoing at the moment. Some of these involve several thousand patients. Some of them are a few patients, but there's one example where this is a full 4-phase clinical trial, which is running where many of these patients were recruited from the registry, and the data that's being collected in the trial can go back into the registry. And because we have this central registry now, we can also say, well, this patient who's now on this particular trial, taking this treatment, should be ineligible for other trials, which might, interact with the trial that they're currently involved in, for example. So by doing that and managing who's involved in which studies, we have much better access to larger scale studies for the researchers. We also try to encourage sites to show who's contributing the most data. So there is some process to get access to the system. So I think it's something like €100 a year is the nominal fee you have to pay to be a member of the community. But it's also the case that the more data you have in the system, the more preference you have for being involved in multiple collaborations and multiple grants, etc. And there'll be many, many grants spinning out as a result of this. The people who are involved are fairly famous in the field. I guess they are the ones who are publishing in the New England Journal of Medicine and Nature, etc. And it's heavily utilized. The system was built in 2011, and we're still running it now. So there's no grant paying for this, but the people are using it and they want it, and it costs me nothing to keep hosting and running it for them effectively. If they keep on asking for more features, add more new data fields, etc., then that's where I have to say, well, someone's got to resource this. I'm not a charity. Obviously, the people who will work on the system are the ones whose jobs depend on future monies coming in to pay their salary. We also have a range of mobile apps for the patients. So we have all the clinical data, all the treatment data, all the sort of demographic data in the platform. But we also have a range of projects with mobile apps for patients. This is one example where we have a clinical database or a registry, and then the patients themselves are heavily involved in populating aspects of their daily ongoing life. So, for example, they have quality of life surveys where they're filling in information about themselves, how are they feeling at any given time, whether they have ongoing challenges with their condition. A lot of the time when patients have certain, treatments like chemotherapy, it can interfere with the metabolism and they can have acute diarrhea or things like this. They might meet the doctor once every couple of months, and when they meet the doctor, it's like, how are you? I'm fine, it was all good. But if you're providing real-time information in the system, you can actually see, for example, the stool samples and how many times they go into the loo, the various daily information about the blood pressure, the pulse, etc., how that's interacting with them after they've had treatment, and other scales like this. What we found in building these apps is that the patients are heavily involved in this, especially for things like cancer. Patients want to feel as though it's not just, they're not the only patients in the world with this condition, but also by contributing data, they can then be, you might be eligible for a particular clinical trial or for a clinical study that is for patients like yourself. So they're very motivated, I guess you could say, to be involved. So that was an example of a completely independent system that we've built that doctors around the world are using. But I mentioned that sometimes we can't just build a separate system where data is being entered manually. So my team also built what we call the Australasian Diabetes Data Network. So this is a type 1 diabetes platform. It's been running now for 8 years. And this basically is aggregating all the type 1 diabetes data for patients across Australia for a range of reasons, I guess, for benchmarking, for informing guidelines of which treatments have the best effect, or which hospitals are better performing than other hospitals, etc. Initially, the focus was on pediatric type 1 diabetes, but since we've been building the system over time, it's now also including adult sites. And there are many sites that are using this, and the system's growing. So many, many more sites are coming on board now because they see the value of being involved in studies and being involved in guidelines and evaluation of how they are doing and what can they do to improve their current management of patients with diabetes. To begin with, in building this system, so this system is based upon data coming from hospitals. So it's not just a separate system, it's actually built to suck in data, I guess you could say. First question is, what is that data? So I mentioned at the beginning that all these different hospitals have heterogeneous platforms. They have databases of various flavors, from Access 94 to Oracle to MySQL to SQL Server to everything. And so we built a system which has a core data set, which is important for the researchers. So the data dictionary, I guess we call it, which has a range of information, demographic information, and treatment information, and the visit information, and et cetera, et cetera. All this data historically has been fully de-identified, as with NSAC cancer. We don't need to know the names and addresses. Moving forward, we've been given permission to make this more fully identifying. So we can actually start linking individual patients with other sets of data, say the National Death Index or the National Prescription Pharmaceutical Benefit Scheme. So anyone who's on medications, you can see which medications they're taking. So, but we defined the database to begin with, and then we implement a system. And what we've been doing is we've been largely helping all the hospitals debug their own data. So hospitals will get data from their systems. We automate that process for them, and they can see any child that's got is 300 kilograms, or anyone who's born, you know, erroneous data here and erroneous values there. They can use it, the system that we've implemented and all the rules that we were told to realize to debug their own data. Once their data is being debugged, we ingest it, and that's done twice a year. And then once the data has been debugged, it then becomes part of the national benchmarking activity. And so researchers can ask questions of about all kinds of different aspects of what's happening with diabetes across Australia. It's an interesting project in many ways. One of the main interesting aspects from my side is our funders, the Juvenile Diabetes Research Foundation, only fund give the money over, I guess, when we meet milestones and deliverables. And some of those are to do with, we have to have so many thousands of patients in the system, which is one thing, but also the quality of the data. So we have to have a certain number of core data sets, which are over a certain percentage of completion. So over 90% completion for all, 44 data items, but there's like 130 something data items in the broader dictionary. The challenge sometimes is some sites don't collect certain data sets and other sites do, but all sites should be collecting the core. I mean, this is like the height, the weight, etc., as well as when were they first diagnosed with diabetes and what type of diabetes, etc. But interestingly, we're only paid the monies from the grant when we hit these deadline with these milestones, which is a kind of an interesting phenomenon. What can they do with this then? Well, they can look at, say, glycemia, which is a diabetes condition, I guess, and see what's the population profile and how many people have a certain. I mean, the national guideline in Australia is 7.5. You should be below 7.5 for your HbA1c. But there are many sites where there are lots of patients exceeding that. And looking at the demographic profile, different sites are treating patients in different ways. So some it can be daily injections. There's a national program right now in Australia rolling out continuous glucose monitors. So this is continuous sort of monitoring the glucose levels, etc. And there's apps and data associated with this. So they're looking at these programs and saying how many individuals have events which are related to the DKA events, etc., which are related to the blood sugar getting totally out of whack, etc. So we've been building lots of things like this. We also have mobile apps. So for the patients, in the previous example, it was individual patients reporting on themselves. With these mobile apps, what we've been building is you can just benchmark yourself. So in this case, we have apps where you can say your age, your height, your weight, your HbA1c level, how you're being treated. And then based on that, then you can say, how do I compare with everybody else like me? So show me all the 12-year-old girls who are about my height and weight. And how do I compare with everybody else, both for my BMI and for my HbA1c levels? Again, there are lots of opportunities, and the technology, I would say, is generally we know how to do it. It's coordinating all of these hospitals to get them on board is really the challenge. Other challenges, I guess, are dealing with the legal aspects and the lawyers and who owns the IP and the confidentiality constraints and the enormous amounts of process that goes through to ethics constraint and consent, etc. And major issues generally, I call it socioeconomics, but there is a real demand for, I mean, everybody wants to share data as long as I can share your data and you don't share my data. And there's an element of that pervades a lot of medical research. I've worked in many projects, and just building a system for everyone to share everything, we've done that many times and it doesn't really work. Researchers want to be able to protect access to the data, their data. And hospitals and sites are very, generally speaking, very paranoid of their data and how it could be used or misused to, you know, this is the worst hospital to go to if you have diabetes, etc. Is something that nobody wants to, you know, publish papers on if you're going to or use someone's data to shame them effectively. I haven't really spoke about the large scale infrastructure that we have where all this runs, but we've many projects, and I guess we do a lot of work in security and security research more generally, and we leverage a lot of those resources. So we have our own private cloud at the University of Melbourne, which is specifically set up to be able to manage a lot of these sort of more sensitive projects. I haven't spoken about the interdisciplinary challenges. So there are the kind of data sets that we've been putting together in those projects. I have many other projects looking at environmental data sets like pollution or sort of socioeconomics. I mean, are they rich? Are they poor? What ethnicity? Which postcode do they live in? What's the average number of bottle shops or fast food restaurants in those areas? We have all these data sets existing in other projects. But the challenge there is that often now you're combining disciplines, and it's no longer just a clinical, a biomedical project. It then becomes this different researchers with different perspectives of the problems at scale. And that's really where a lot of the bigger projects and the nutty problems get sorted out. And a final notice to make on this talk is that I generally speaking say to all the people that for the projects I'm involved in, we'll sustain it over the long term, even outside. That has repercussions for the university in terms of our legal obligation of doing this. I mean, generally speaking, I should not be doing things outside of a contract. I mean, if a contract runs for 5 years, everything after 5 years is officially it shouldn't happen. But I guess this is something I have so many resources and so many collaborations. It helps because these people remember what I do, and then they come back to me later on with new grants and new opportunities. Okay, I think I'll stop sharing now, and I'm happy to answer any questions if there are any.
Thank you very much, Richard. This was absolutely fascinating, really interesting talk, and I really like the different case examples that you gave and sort of the lessons that you've learned over the years of what works in research and working with people, and also your reflections, I think, of, since this is a sort of event series on open digital health, this idea that maybe not putting all the data out there is always sort of working, and that there are some issues connected to that from your experience was very interesting to hear about. So thanks again, and we would like to open it up for any questions for Richard at this point. Feel free to raise your hand, unmute yourself, or if you like, you can also post a question in the chat, and I'm happy to take those questions as well. So yeah, if while we're waiting for questions, I of course have some questions in mind for Richard. The last thing actually that you talked about in your conclusions was something that I wanted you to maybe reflect a little bit more on, this idea of maintaining those systems, because I think this is also one of the reasons why we started this initiative, was that once you develop a digital health solution, that there's always a risk that once the project finishes, that the solution will not be carried on. Maybe somebody, no funding is obtained. If you have any other further kind of reflections or tips for people in the audience of how to maintain this kind of constant funding stream, or how to maintain sort of collaborations that will allow funding opportunities in the future.
It's hard. I mean, you need a critical mass to be able to do these things. I mean, if you have a project and you have one postdoc, for argument's sake, working on it, and then you try to get the second project, which builds on the first project, and you don't get the grant, then the postdoc's going to leave. And so you can't make any promises. But I've got to a point now with my team where I have a lot of people who can run and manage systems. We call them DevOps. So we people whose sole job it is to manage systems on and make sure they don't go down, etc. And we can do that. Part of the challenge, I guess, in doing these things, though, and I sort of, there was a note I should have made on the Aden example, is when you have dependencies which are external, as in the remote hospitals change their firewall rules or they've changed their data model, etc., that breaks things. If I build a system which is completely just a web application with a database and it doesn't talk to anything, you generally want to be able to patch those things and upgrade them periodically, because, you know, Java gets updated and the database technology grows for whatever reason. Then, but you can manage that, generally speaking, within certain limitations. I mean, some of my projects are hugely complicated. We have millions of lines of code, and it interfaces to 200 government agencies, not in the medical domain, but in other disciplines. We're doing lots of big software engineering projects, and things can break. And those things can break not because our technology failed, something that we depend. This is a classic example of a distributed system. Your system breaks because it used a thing you didn't even know existed somewhere, and that causes it to break. So there are real challenges in those kind of systems. But hosting and running and maintaining a system like NSAT, as an example, is we can do that quite straightforwardly. The people who work on this project still work on related projects. There's a community of people that we work with. They engage with us. They write papers with us. And it's not a massive undertaking from our side to keep it going. But if you don't have a bigger team and you are, I mean, the university generally saying, well, we're not pro bono, we make money. We want people to pay for anything we do. At some point, you need to be able to be a bit more flexible. If I was just a purely business oriented and only did things when people paid me and then I turned it off as soon as the money went, that's not the way to build relationships. That is purely, I'm just, a business for hire kind of thing. And that's not the way it should be, I guess. But you need a critical mass of people to do it.
And that's very good advice. And I think it's a bit what we're trying to do here as well, is to bring people together who have similar interests. And I think you're really always dependent on that people are interested to take it forward. So we have a question here coming in the chat before I hand it over to Efrat. So Dominika is complimenting and says that she liked the different variety of projects, and is asking whether you could elaborate on how open science movement aligns or doesn't align with all the work that you do. Is there a scope to share some of the data anonymized, maybe with researchers who may not be able to contribute data in exchange, but maybe work on data analysis? That's a good question.
Sure. So I guess there's a few things to say there. So I work in, the work I do with the US defense, of all people, is to do with open science and repeatability of science. So we have projects where we've been given quite a sizable amount of money to look at taking 3,000 publications in the social and psychological sciences and having them rated about, could you repeat the science in them by experts. So we had several thousand experts all looking at papers in, substance abuse or psychological testing, etc., and saying, because the real challenge a lot of the time now is how, I can write a paper, but no one can repeat my results because the system doesn't work anymore, or the data's gone, or the postdoc left, and no one knows where the data is anymore, all those kind of things. And this is pervasive across lots of different disciplines. So we have projects in that area looking at repeatability of science, and also looking at the powers of papers and how you can analyze the papers to say, is this a variation on a theme, or is it groundbreaking, etc. So there's a whole range of things in that area we're doing. There's also the access to data. This is something which is generally speaking, every project I'm involved in, which has dealing with some aspects of sensitive data, there is some form of process to decide who can access this data. So in the case of the diabetes project, we have a web form. You fill in the web form. You say, I'm interested in getting access to an export of all your data because I'm interested in hypertension or obesity in children or whatever the scenario might be. That gets reviewed then by the clinicians, about do we trust this person? Is it, do we allow this to happen? Would this be novel research, or is it just whatever? And then if the answer is yes to that, then my team will generate the data from the system and provide that as typically it's like spreadsheets or CSV files, something along those lines. But that's a very common model. But we can also do more aggregated data release. So I've done a lot of work combining, how many patients per postcode and with diabetes, and then how does that correlate with all the other data I have accessible. So, the average income in those areas, the number of parks in those areas, the number of fast food restaurants in those areas. And I don't really need to know anything about the patients other than they live in a certain area. And I want to see how does diabetes, what's the context of, where diabetes happens? Well, is it just, type 1 diabetes is slightly different than type 2, but type 2 diabetes, it's because increasingly prevalent in children because they're all sitting in front of a computer screen eating Uber Eats all the time. They're not exercising. Is it because there's no parks left for them to play? Or is it because mom and dad are driving them everywhere anymore and the children don't play in the streets? But you have all these rich questions that can be asked, and it's a case of exporting the data to answer them. There's a process to go through, long story short.
Yes,
another question.
Thank you. Yeah, Efrat, do you want to say your question, or shall I read it for you?
I posted it, so
Okay, I can.
Oh, I can say it. I was wondering about the people with the conditions and their use of the data. You mentioned that they can compare themselves to others.
Yep.
And I was wondering whether you or anyone in the team or the project looked at what the effect of the comparison. One of the issues with social media is the comparisons that it makes us have. So I was wondering about this aspect in your data.
The different projects. So let's say if I take the example of diabetes again. So we have patient advisory groups who are involved in the project. So they are the ones who are looking at the data we're collecting and, the impact on the patients themselves. And so in Australia, they're rolling out these continuous glucose monitors. And there are policies of the government about some people have it for free, some people have to pay for it. And what happens, is it good for you if you get one, etc. And so the patients are heavily involved from that perspective. So they can see, the benefits of having this technology is much, it seems to have a much greater effect on the impact of the quality of life and reducing the amount of events, diabetic events that the patients would otherwise have. The question then becomes, well, why can we just roll this out to all patients, which then becomes a monetary question and a political question, and who's going to pay for it when you've got all these challenges of what can be funded, etc. In other projects, the patients are very much driving the science, I guess is one way to describe it. So they know, like say cancer projects, they know how they are, and they know how they're ranking of, am I the only one that had, acute diarrhea for 3 weeks following that treatment, or is everyone like me? So we produce graphs and charts to say, this is typical for someone like you. This is how you're not abnormal. This is typical sort of typical side effect of being treated with this condition. But what do we do with that then is, the patients don't write the papers, generally speaking. They get some, okay, now I now understand how you're using my data, and I'm happy to continue to contribute if it helps. But it's mostly the scientists that would want to write these papers about the psychological effects of, patient involvement in studies, etc. But generally speaking, the patients are, especially in some of the projects, quite vociferous and quite active and quite demanding of, what's happening with their data and why isn't it being used more, etc. So they're quite sort of keen to push the research in different ways, which is more than, it wasn't something I was imagining, because a lot of the time, if I had to paraphrase a lot of the medical data projects I'm involved in, the patients are not involved. It's actually the data. The scientists are using this data, they're writing papers and getting famous, etc. But the patients have no idea that their data they were impatient, that Nature paper was me. my data was there. I was the outlier, or I was the, those kind of things. And so what we're doing now with the whole GDPR, sort of, I guess everyone knows about GDPR. It's kind of the new data sharing sort of demands, I guess, where patients have to be informed about how their data is being used, and also have the right to say, stop using my data. But we're building mobile applications now where anyone who runs a query and wants to have access to someone's data, the patients get notified through an app and say yes or no. So right now, with the models we have, typically when you consent to be involved in a registry, your data can now be accessed and used by researchers for stuff. And that could be any stuff. With moving forward, if your data is being used for various studies, you should be able to opt in or opt out of those studies. You should know which studies they're going to use your data for. So with the ADAM project, we're in the process now of publishing mobile apps where anyone who tries to access that data, the patients get notified. Do you want to be in that study or not? And if they say not, or they can even say, no, actually, why am I on your registry? No one, all the patients.
Is it opt in or opt out? Is it opt in or opt out?
So this is another interesting, it's supposed to be opt in, but the opt in is done locally at the hospitals. And somewhere there's a piece of paper that's signed, but I just assume that everyone is doing the right thing, but it may well be the case that we're just getting data from a hospital where that opt in flag has not been set, or that PDF has not been inspected, because there's no policing of a lot of this stuff. And it's one thing having a policy, but unless someone's going to police it and check and slap you on the wrist if you're doing bad things, and I'm not saying anybody is, but if you really want to check the ethical use of data in the medical domain, then you need ways to enforce it and check it. And that seems not to be happening anywhere near as much as I would have imagined it would in many countries. So data is being used, and the patients generally have supposed to have consented, and there's been opt in, opt out. There are a range of models we've implemented over the years, depending on the country. Different countries have different perspectives on this. Some countries have a far more rigorous sort of enforcement of what does it mean to opt in, and do you have the patient's information sheets, etc. Whereas other countries are a bit more laissez-faire about the whole process, I guess is one way to describe it.
Thank you very much, Efrat, for your question. We have another question here coming through in the chat by Philippe, who is asking, my question is about the European Health Data Space Initiative. Let me just scroll down. This health specific ecosystem comprises common standards, infrastructures, and a governance framework for the use of health data. What do you think of this initiative and the impact it may have in research, innovation, and transformation of healthcare? Any other international initiatives in that direction that you know? How do you think this may help?
I don't know the details of the European health data space. I can say, having worked a lot, is more often than not, there are more standards and there are more processes and more frameworks, and there are more ideas put forward for how to do it. But when you look at the real world of what happens inside hospitals, they are far, far removed from those activities. So they're using technologies that's obsolete a lot of the time. They have Windows PCs from 20 years ago that are being used in ICUs, and this is the real world of many hospitals. Some countries are better than others, but I've worked in places where you think, how is this allowed to happen? So just as one example, so the pandemic is a good example. So the national pandemic system we had in Australia, we had a infectious disease reporting system that was based on a DOS-based Windows system that my team were asked to upgrade. And so we built them a proper database and a proper ways for when patients go with flu-like symptoms to this is pre-pandemic, by the way, with flu-like symptoms to the GPs want to know if it's a new strain of flu, and if so, it has to be reported that they haven't seen before. Before, in 2018, I think we did that project, there was nothing. And then we had the pandemic takes off, and they suddenly realized, hang on, we need to get all this data together. Well, who's responsible for this? And this is kind of the real world of what you want in terms of the technologies and the standards and the frameworks is wonderful. But unless organizations are going to be forced to deliver and kept honest. And if I'm really being cynical now, I think there's way too much money pours into big hospital systems, and it's big corporations that take it and don't deliver. And this is this is kind of being the way it is. I'll finish this with one anecdote. So I once gave a keynote at a conference in the UK, and my mother was in the audience, believe it or not. And I was talking about Connecting for Health, which was the big multi-billion pound integrated system for the National Health Service in the UK. And it was a complete disaster. They had massive amounts of money and they failed to deliver anything. And I was fairly blunt. I mean, you can sort of say I say what I think, and so I raised questions about the whole process and why it was fundamentally flawed, etc. And then there were a bunch of people in the audience who were working on that project, and they didn't like me, so they started haranguing me while I'm standing on the stage, etc. But this is kind of a very typical model of your major corporations who get billions of dollars or hundreds of millions of dollars for IT, for delivery of wonderful glossy PowerPoint slides, and it's all going to be wonderful if you buy our technology. And then they buy the technology, and if you want to add an extra table, it's going to cost you $200,000. If you want to change a field, it's going to cost you X amount. It's about money and business. The projects I've just described, the national projects, international projects, they had 2 techies, one on each to deliver. You don't need billions of dollars, but for some reason, a lot of the time, IT and health seems to be this pit of, pouring money into it. And then you look at where's the outputs of this now? Where's this wonderful integrated system? Every hospital has completely diverse admin systems, ICU systems, reporting systems, research systems. Generally speaking, from my experience, has been the doctors are doing it themselves. They are creating their own little access database or their own spreadsheets of patients who have that condition that they're interested in. And it's like a little cottage industry of the doctors having a go. I mean, they're not stupid, obviously, but they're not techies. Their job's not to be software engineers. So they try to use FileMaker Pro, or they try to use Access, or they try to use something which gets them so far, but then they rapidly find out it gets more complicated and they need to spend more time doing it. But this is the reality, I guess, of a lot of the way IT works in the medical domain.
Thanks, Richard, for this anecdote. I think I'm not seeing any further questions coming through, and I realize it's also really late for Richard already. It's almost 8 p.m. in Australia. So I think we should better let him go at this point. He's shared so much interesting knowledge for all of us. Before I let everybody go, if you could please go to the survey that I post in the comment, just to evaluate our event series. That would be extremely helpful for us to help improve this in the future. So thanks again, everyone, for coming and participating in this event. Thanks again, Richard, for giving your time and this interesting presentation.
All good, folks. Take care.
Good to meet you.
Yes, now.
Okay.
Bye-bye now.
Thank you. Bye.